a lot from Joseph, who is going to be the discussant of today's case. So I think we can start while others they are joining us. They'll find us in mid journey. Is it okay, Joseph, if we start?
Yes, Roland, let's start. They'll join us.
Okay. So to start with, it's a 24 years old male who presented with shortness of breath for 5 months, chest pain for 2 months, and reduced urine output for 1 month. So Joseph is going to start from here before we continue to the HPI and the rest part of history. So Dr. Joseph, you're welcome.
Yeah, thank you. So many chief complaints. I'll be brief in this area. Starting with the most important of all, this is the age of this patient, 24 years old. It's so unfortunate. The patient has lived for longer, for example, to accumulate a lot of risk factors that will result in diagnosis which present with complaints like this. So you realize at the end, maybe it's just a bad luck that it happens in life, or otherwise it's risky behaviors that we tend to have during around these ages, which include maybe use of drugs, sexual activity, and yeah, and the other one is maybe genetics. You're born with some bad genes, and then they put you in a risk to get diseases. So, of the three complaints, I think for me, the one which catches my attention is the shortness of breath, which preceded everything else that's followed up. And as we talk here, when we see shortness of breath, we put in what we say a Disney pyramid. Disney pyramid is the one which you have. If you take maybe 100 patients with dyspnea and you put a pyramid, you find that most will fall at the bottom of that pyramid. They will have diseases of the lung or heart. And then the next, when you go up the pyramid, you find other localization now. Maybe it's a neuro disease, maybe it's anemia, maybe it's anxiety, maybe it's obesity, hyperventilation syndrome. Those are few, but at the end of the day, usually you find that the diagnosis sits in the cardiac system or in the respiratory. But when you say chest pain now, you wonder, is it related to that SOB? And in the chest, a lot of structures from outside to the skin, subcutaneous tissues, skeletal muscles, bones, pleural space, pericardium, myocardium, valves, anything of that category can be painful. Reduced urine output. Why you have reduced output is, are your kidneys failing, or maybe in how even you are measuring it, that you have reduced urine output. So just before even patient have reduced urine output, you wonder, is this a kidney thing? You just send a creatinine because that rise up first before the urine volume goes down. So let me stop there to leave time for HPI and more discussion. Roland.
Yes, thank you, Joseph, for a brief startup. Our patient presented with shortness of breath of 5 months, which was gradual onset, initially occurring on exertion. But 2 months later, it worsened even in minimal activities. Currents gets out of breath with even self-care activities. The shortness of breath is relieved by rest. However, it is associated with difficulties in breathing on lying flat, which started 4 months ago. And initially, it required one pillow for him to sleep comfortably, but currently uses 3 pillows. Also reported air hunger at night together with fatigue. No dizziness or syncope was reported by him. And the slide, okay, it's moving. So, sorry. My slide is not moving. Let me see what's happening.
We see.
Let's see. Yes. So sorry. Um, After the shortness of breath of 5 months, also patient has chest pain of 2 months of gradual onset, which is centrally located. The patient described it as deep, dull aching, and it was radiating to the back with no change in intensity and no specific periodicity. It wasn't aggravated by positional change or exertion, but the description of this pain, of the chest pain, it was scored at 2 to 3 by visual analog scale. It was associated with awareness of heartbeat on exertion, which was the intermittent, irregular pattern, described as forceful pounding, racing sensation on the chest, with no cough, no sputum, no wheezes, no fever, no night sweat, no loss of weight. Also, the third complaint, which is reduced urine output, was of 1 month, which was gradual onset initially, and initially noted decrease in amount of urine from approximately 1,500 mils per day to 500 mils in a duration of 2 days. Also noted a decrease in urination episodes from four urination per day to one episode in 2 days. He noted no increase upon he noted no increase of urination even when he tried to increase fluid intake. No pain during urination, no change in urine color, blood in urine. The reduced urine output was associated with bilateral or non-painful lower limb swelling to the level of thighs, which was worsening at rest and was relieved when using some IV medications. This reduction of urine output was not associated with flank pain, no facial periorbital swelling. There was no difficulty in urine initiation, no weak stream which improves on straining, no terminal dribbling, no feeling of incomplete bladder emptying. No also deep yellow colored urine. There was no nausea, no vomiting, no passage of a loose stool, no pale colored stool, no abdominal distension, no skin discoloration, and there was no also excessive itching. So this was the HPI, Dr. Joseph. We can continue, then later I'll
Uh,
come and finish the last part
can
of
you
it.
can you complete the review of other systems because it's a lot of slides, so that we just complete the HPI and the review of other systems.
Okay, so the review of other system were okay, except nervous system where patient reported history of difficulties in seeing distant objects with no history of headache, confusion, blurring of vision, decreased sense of smell, slurring of speech. Neither was there any limb weakness. The past medical issue of this patient was diagnosed with myopic vision in 2021 with a history of 2 months use of spectacles. However, he stopped using them after completing his college education. There was no report of drug or food allergy, no surgery, no prior admission, no blood transfusion. On developmental history to this patient, his natal, postnatal, together with developmental milestone, nothing abnormal was there. But on behavioral development and adolescent history, while growing up, his peers noted that he was significantly taller, comparing him with the rest of the group. On a family social history of this 24 years male, he's married with one child, and currently his wife is pregnant with a second expected child. He's the seventh born in a family of 9 children, shares similar father with 3 of his siblings, of which among them he happens to be the firstborn. And the sister has similar presentation of tallness. um, no, the mother is hypertensive with no sudden death in family. In the family, there was no any other familial illnesses, no alcohol, no smoking, has no history of multiple partners, no history of illicit and IV drug use or keeping pets. In dietary history, pre-illness, the dietary was adequate and in quality and quantity. But during the index illness, he reported to have reduced the quantity of number of meals he take per day. But however, the adequate is just quality. And with this comes also with reduced fluid intake from 3 liters to 1 liters a day. So this was his HPI together with past medical history, family together with dietary history.
Okay.
So back to you, Dr. J.
Thank you very much, Roland. That's a well elaborated history. This is a good case because there's a lot of things to learn in this case for me and for everyone who is attending this session today. So let's see. We've tried to we've tried to go deep on these complaints of these young male, and maybe if you see, we are trying to figure out where is this disease located. So, as I said initially in the chest pain, that I mean, in the shortness of breath, that at the end of the day, uh, the disease which will explain all these complaints of the patient will be sitting in maybe in larger percent in the lungs or the cardiac. And I'll, I'll try to say, is that the case? Or maybe it's others, because heart, lung on one end, others on the other. And I think looking at the other symptoms that the patient has, you realize it's not others. Because when I say others, it's the thing that I've talked about, that maybe it's a neurological disorder. You have weakness of the respiratory muscles, you start having shortness of breath, for example, or you have anemia, or you have obesity hypoventilation syndrome. You realize you don't hear anything. You don't hear anything about neuro. You don't hear anything regarding just anemia. If you say it's anemia, you can't explain chest pain. So you say, no, it's not others. This is heart lung. So between heart lung, which one is it heart or is it lung? If lung causes difficulty in breathing, you like want to hear things like a cough, for example, which we didn't hear. But yeah, you can have a pathology of the lung which causes this shortness of breath without a cough. Think of a PE, for example. You should maybe no cough, minimal cough, and then you have difficulty breathing because of PE, and it's a problem of the lung. Or a massive pleural effusion, for example. So you wonder, is this the lung? But if you say it's the lung, where is the pain coming from? Uh, Lungs themselves are not painful. Um, the reason people with PE get pain is not because the lungs lacks uh, lacks blood. It's the pleura which lacks the blood. It's the pleura that has pain receptors. So once it is chest pain plus SOB, is more likely to be the cardiac pathology. But there is something else here. We combine that plus that this patient has reduced urine output despite taking normal fluids, and then they are having lower limb swelling. It means they're taking in the fluid doesn't come out. Why is it coming out? If there was an obstruction somewhere, it wouldn't take a month as it is reported here. And then an obstruction will be painful. So we realize this is not an obstruction. This is the fluid that is inside the patient is not coming out through the usual systems that is involved with urination, and the fluid is distributed everywhere in the body. That's why the patient has lower limb swelling, plus has other symptoms like orthopnea and PND that we've heard here, orthopnea and PND. But you wonder if the case is just cardiac, because again that points to the cardiac. and I mean heart failure here, that you have something which causes the heart to fail. That thing also causes the heart to be painful. But again, if the heart is not pumping out, you have water sitting in your body, you have swelling. But that wouldn't explain why would the patient have reduced your output. So as I said, okay, we are discussing here as the HPI. By the end of the day, you have to send a creatinine. But usually, when you're in the hospital, you hear someone like this saying, "IP, doctor, IP less and less." You say, maybe the kidneys are failing. So if the kidneys of this patient are failing, so maybe this is another pathology that the patient has a cardiac pathology, which will explain SOB, chest pain, plus those other symptoms like orthopnea, PND, and they have a pathology of the kidneys that also causes the kidney not to excrete enough fluid for them to form enough urine. I'm spending my time here because as you get used to seeing patients, you realize usually it's okay that you see a patient and you, you quickly run to say this is a diagnosis, and people admire that. But at the end of the day, if you start missing diagnosis and sometimes miss something so obvious, you realize it's better to characterize the problem than arrive at a diagnosis. If you characterize the problem well, you have your problem representation statement. That statement, even if you don't have a diagnosis, you put it in maybe ChatGPT or maybe any such drive, you get the diagnosis. So I'm spending my time here trying to say, so what's the problem here? And for me, I think right now we are dealing with some two problems that come in and cause somewhat similar symptoms. We're dealing maybe with the problem of the cardiac, and we're also dealing with the problem of the kidneys in this patient. So I start asking, in 24 years old, what are the problems of the cardiac that can cause rapidly progressive heart failure like this? Because 5 months for me is rapid. For the patient that you have, if you follow a patient, for example, say a patient with hypertension or ischemic heart disease, up to the time that they will develop heart failure, it takes time, it takes years, unless they had a very bad catastrophe initially, like maybe ACS. But for someone who was normal in 5 months, they started to have some symptoms. All of a sudden, they're having SOB right now. It's a rapidly progressive heart failure. So again, you go down and start maybe putting what are the causes now, what are the issues with as far as that failure is concerned. But I won't do it right now. It will be premature. I'll wait until I have further data that I'm sure, okay, we're dealing with that failure now. What's the cause here? And then where would the pain be coming from? So if I say the pain is coming from the cardiac, I think two or three structures. First of all, is the pericardium, which can have both pain, and if the pericardium is inflamed enough to have pain, pours fluid in the pericardial space, causes symptoms like that, those you see in heart failure due to obstruction. But again, you can have diseases of the vessels that supplies the myocardium when they are impaired in some sort. You also have pain coming from from the myocardium. The same applied with the valvular diseases. If you have valvular diseases in places where blood doesn't flow as it should, blood also doesn't flow to the myocardium as it should, and then you have pain. If you live in this country and you've seen young patients with cardiac disease, you have seen rheumatic heart disease patient who, some of them will have chest pain as you know it. And another is so those are the symptoms we have localized. We think here are the problems, and then we are told that patient has myopia. They can't see far. I also have myopia. I had it since I knew myself back then. So it's a very common thing, like in medical school. A lot of people are wearing these glasses. You have myopia. Should we focus our attention in this myopia of the patient? But it looks weird. Since I, for example, take myself, since I started wearing my glasses up to there, I still need my glasses, and I even keep increasing what the numbers when I go and check my eyes. But this patient wear glass, and then they don't wear glass. Okay. At one point, when we grow up, we get the presbyopia, and then you reverse myopia. But this is not the age for that thing. So maybe they were. I didn't catch it. Maybe they were not helpful. So if they are not helpful, so it's something else. We should keep it aside to say what is happening with the lenses of this patient. What is happening with the lenses of the patient? And again, very important in this, whoever person was taking the history had to ask about um, the hate of the patient. That is concerning. The way someone is seeing the patient. So this hate is concerning. What's happening? And then the sister also is the same. Um, so pattern recognition now, pattern recognition is when you see things trying to take a similar a pattern that you say maybe this, but there is a very important point about pattern recognition. You shouldn't rush. Like now, I can say we're seeing a patient with cardiac lung pathology, plus maybe dislocated lenses and an abnormal height. And if you put that in the Google, maybe in your Google, wherever, you start seeing things, Marfan and others, but you shouldn't rush. We say, okay, let's go slowly. This is what is called tall. A lot of people are taller than you say, oh, the guy is too tall. But there are tests now, and I think they will be done in the physical exam. You measure the test, you measure the limbs, and then you measure the upper limbs and the height. You compare in that manner. So let me pause here and listen for the next aliquots, and I see if I put things into perspective. Thank you.
Yes, thank you so much, Joseph, for such a wonderful schema. So let's proceed. On examination, on general examination, the patient was jaundiced with high active palate with dental overcrowding. There was no skin hyperextensibility, but also was noted to have bilateral pitting lower limb edema graded at grade 1. The vitals and anthropometric measurement, the vitals, the blood pressure was within normal range on both arms, the right arm and left arm, and the pulse pressure when measured was at 36 millimeters of mercury, and ankle brachial index was at 1.2. The pulse rate, saturation, respiratory rate, and temperature were also in keeping with normal findings. His weight was 54 kilograms and the height at 175 centimeters. So if you check his BMI was a bit under. It was at 17.6 kilogram per meter square. And this was the appearance. So you can see his active palate. But also, if you look on his left dental, you will see there is stripe. The cardiovascular system. So I just had to highlight for Joseph the important pertinent issues. They are the one in bold, so they are bolded. So I'll just go through them. So he had the regular radial pulse with pulse deficit of 16 beats per minute, and the positive water hammer pulse with positive heel sign and raised jugular venous pressure of 10 centimeters from the right atrium. And he's having negative peripheral vascular signs. Speaking of the Corrigan, the Mueller, the Rosenbach, they were all negative. On precordial examination, he had hyperactivity, and the location of the apex beat was felt at a 6 intercostal space along a midclavicular line, and noted also with apical heave and systolic thrill, which was palpable at the apex. The sound, heart sound one and heart sound two were head and normal, but he had grade 4 pansystolic murmur at the apex with radiation to the left axilla, together with grade 3 early diastolic decrescendo murmur head at the left sternal border at a fourth intercostal space, which was accentuated by leaning forward and holding breath. The respiratory and musculoskeletal system, he had a finding of a bilateral fine inspiratory crack on lungs during respiratory examination, with the rest part being normal. On abdomen, he had a liver span of 18 centimeter, which was tender. However, it had smooth surface and with regular margin. In a musculoskeletal examination, he was thin stature, had high palate with dental overcrowding, and he was noted to have arachnodactyly with a positive Walker-Maddox sign and positive Steinberg sign with reduced elbow extension and scoliosis. The Dayton score to this patient was 0, with 0 being the lowest and 9 being the highest. And this is his pictorial presentation. As you can see, Dr. Joseph, you can appreciate if he extends his arm or if he stretches them, they are measuring 176 centimeters. So his upper, if you look to the upper part, the upper segment and the lower segment for him, the ratio will be 0.5, and the arm span to height is at 1.01. You can see his arms. This is how they're looking, and this is how also they are looking. Another photo. You can appreciate the scoliosis to this patient as depicted in the exam, and on nervous system, the higher center together with meningeal irritation signs, they were all they were normal. That means no meningeal irritation. Higher centers were normal. On cranial nerve examination, they were all intact except cranial nerve number 3, where I had a visual acuity on the right eye of 16 out of 12, and the left eye, it was at 6/15. On further doing of ocular examination on anterior segment, the patient had insignificant intraoptic pressure discrepancy, on the right eye being 12 and the left eye being 10. But on the posterior segment now, it revealed early nuclear sclerotic cataract grade 1 with supranasal lens subluxation and a stretched zonules infratemporally. These were how the eyes were looking. You can appreciate the detachment of the lens with halo sign in the right eye. Same or similar presentation, they're also present on the left eye. So you can now have a discussion up to here, Joseph, before we look upon the investigations which our patient did. You are welcome, Chief.
Um, uh, um, I'm impressed with the whoever took the history and those exam findings. So let me try to unpack something. So it's not about the diagnosis I'm saying. It's trying now to like put everything in one bucket and try to explain them. So let's start with the general exam. We saw this patient is jaundice. And I will connect jaundice to the abdominal exam because when you have jaundice, it's only two pathologies. It's either you are hemolyzing or you have a problem in the hepatobiliary system. Is the patient hemolyzing? Never. There is nothing like that. So this patient has a problem with the hepatobiliary system. They were palpated in the abdomen, and it seemed that they have tender hepatomegaly. So you plus that with the finding that we saw in the CVS, and we know from history this patient is at failure. We say this is congestive hepatopathy of a patient with heart failure. And we put that aside because that is, by the way, still it won't take us anywhere. Let's find things which will take us somewhere, like the important things that the patient has. Something else, I won't do anything with the IAC palette, dental overcrowding. Leave it there. I will find stuff which will, to be honest, I don't know that if it's there in what I'm trying to think right now, but one or two information which you can't explain in a patient doesn't mean you shouldn't arrive at diagnosis. You take what you can explain and try to figure out whether the one you're seeing is also associated. But oral lymphedema, again, we know this patient has had failure. We've been told we've been told from the history what we are seeing now. During edema, we were told in the HPI that they have it, so nothing new. They have also skin hyperextensibility. So skin hyperextensibility, when you see it, it can be a pathology or not. But I listened to one podcast recently, and then it said it's usually a pathology, even if those patients won't come to the hospital, because unless they come in sick, someone will do some tests. But even those with skin extensibility, in which they roam around and do sports, if you take their genetics, they say you find some connective tissue disorder. There are so many, I realized, just a few that we know. There are others with funny names, and I won't I can't even remember them here. We'll try to recall what we know, and you learn them even in the basic sciences, the Ehlers, Danlos, Marfan, and others. So the anthropometric measurement, pretty much important to measure blood pressure in both arms of this patient. And the reason is in young patients who come in with chest pain, and once they have chest pain at failure, you wonder, do they have pathologies of the blood vessels? And if that's the case, you can have maybe patient with vasculitis. And in patient with large vessel vasculitis who present maybe with Takayasu, they have different blood pressures on different arms. So this was very important. A pulse pressure of 36. I think this is elevated. I think this is elevated. Pulse pressure of 36. And for me, when a pulse pressure is elevated, because it's, it's just a difference between systolic and diastolic, I believe. And so what happens is that there is like a rapid filling of the heart. Whatever is happening is causing rapid filling. So you can have systemic diseases, but you can have localized disease of the cardiac. In a patient, for example, with let's say with anemia, trying to compensate, they fill their heart rapidly. They have wide pulse pressure. Uh, Patients with thyrotoxicosis, the body needs a lot of blood in a faster way. They also have wide pulse pressure. Now you come into the localized um, diseases. They're usually diseases of the valves. And here, what I can remember is mainly, so when blood comes in, I think is the aortic valve, if I remember well. If you have, I think it's AER, the aortic regurgitation, you can have a wide pulse pressure. Plus, um, can you guys hear me? Hello? Hello, Laurent?
Yes, I can now hear you, Joseph. You were describing something, then you just went off.
Uh-huh. Where was the end?
You were discussing about the vessel, something vascular,
Okay.
which is has to. Then you have to check the blood pressures on both arms.
Oh,
So it was at that.
okay. Uh-huh. Yeah, so I went on and discussed about the wide blood pressure, and I said you can have systemic causes like anemia, thyrotoxicosis, and even and localized disease of the cardiac, which are mainly valvular in origin, like aortic regurgitation. So other findings which are very important in this patient is the stria that you showed. Can you show us the stria again? Yeah. So I won't call this as a stria for myself. A stria is the line that you see, like if you have ever seen a patient with a Cushing, for example, or pregnant women, those are strias. But this, for me, is not a stria. For me, I think I can say, I don't know, but an ecchymosis would be too much of a name. But this is someone who is like with my with some sort of bleeding in their skin. I think, unless I'm not seeing it well, but okay, maybe it's a stria, but I think I'm not seeing it from here if it's a stria, because a stria means stretching, stretching. If the stria, if you really saw stria, if a stria is skin colored, you don't worry, it's just normal stretching. If a stria is another color, like a pink color, like this patient, then that's something else altogether. But for me, I think this is, as we say, this patient is like a connective tissue disorder. Their vessels are also breaking up under the skin. So what you're seeing here, I think, is that pathology. So another very important thing is the mammals. Can I see the side for the mammals? I should say they were complicated for me, but I'll try. So seeing a pansysteric mamma at the apex, and at the apex is I think it's the mitral valve, and when you have a pansysteric mamma there, maybe you're dealing with the MR, I think, and then also they also heard a mamma at the left sternal border, a decrescendo mama. I think this is the mama of an ARA. Correct me if I'm wrong. So even if you can't interpret that, you say this patient has valvular heart disease. So now we have something. We say this patient is a failure. There are a lot of causes. The pathology can be from the vessels, the the muscles, the valves, and then we know the patient has valvular heart disease. So that's not the end. You keep asking why at every point. Why are the patient having a valvular heart disease? So around here, uh, many young patients with valvular heart disease would end up be having a rheumatic heart disease. But you realize rheumatic heart disease won't explain a lot of other things here. For me, I'm getting away from that rheumatic heart disease thing, because the one thing just sitting in there, this patient has a syndrome. They have issues with their heart. They have issues with their musculoskeletal system. They have a syndrome that needs to be explained. And then from the musculoskeletal system, uh, I can be okay with others. But what I remember most from my reading is the arm height length. I think that shouldn't be like that. That's like above one. There is a number, but I maybe you tell us the cutoff. But I think this is like equal. Even the arm's length is wider than the height of the patient. So this patient has a connective tissue, a genetic connective tissue disorder, which affects the connective tissue of the skin, even the growth plates. the lenses, the lens subluxation, everything. So it calls for Marfan, the top 3 diagnosis. But you be careful. You have also things which can look like Marfan, but they are not Marfan. And I think I once saw a case, and I was reading that case. There was some diagnosis. I can,
My internet.
yes, David.
Yeah, so you are breaking at multiple points. It's so your voice comes and disappears. Maybe you can also try and fix your internet. I'm not sure if it's just me or if it's the same with everyone else.
Roland, can you hear me? Okay.
Dr. Joseph, yes, I can hear you all through from
Mm.
the point where I interrupted you earlier.
Okay.
From that moment to now,
Yeah.
I haven't heard any break
Yeah.
from my
Okay.
side, but I don't know, maybe others, they can also confirm.
Okay. I think my internet is good around here. Okay. Let's continue. So, okay. Thank you, Brian. I'm saying here, so it's Mafan, but what are the things that can look like Mafan? They exist, but I only remember one. It's called Lois Deeds. But Lois Deeds, so the diagnosis in that case, so it was a CPC case. The diagnosis in that case was a Lois Deed. That's why I remember. But there are others that I can't recall because they are so rare. What Lois Deeds uh, what Lois Deeds has um, is so this patient will have the split uvula or a cleft palate, which is our patient didn't have. They only have high act palate palates, and there is something about the eyes that I can remember. But someone can type in Marfan's mimica and you can see them. But how do we Marfans with this patient before everything else? So because Marfan can explain aortic artery disease, they can explain the lens subluxation, they can explain the rash that you saw on the patient, and they can explain the musculoskeletal thing that you're seeing here. Can it explain the reduced urine output? I have to see the creatinine first before saying that. So back to you, Roland. Roland, you're muted.
Okay, so the other part, Joseph, yes, as you have seen, this is the ocular finding. So let's continue now on the investigation part with this patient. He did full blood picture, and I think you can appreciate this. These were the findings. He did serology, hepatitis, BNC together with HIV. They were all negative. He had raised macrolita together with BUN. The cardiac marker, the NT-proBNP, was also raised. Electrolytes and thyroid were all at normal ranges. On liver enzyme and function tests, he had raised bilirubin, directed bilirubin total. This was his ECG. You can see and appreciate it. Then this is his chest X-ray that he did, his echo, he did a CT scan together with the pelvic X-ray, and the findings, as you can see here, this is an ischiac line or a Euler's line, and sorry, I think the marker is missing. He's missing something. It should point this at this acetabulum here with the head of the femur. The ratio between the two is there is a distance which is 5 millimeters. So pardon me, my slide didn't depict what I wanted to show here, but the protrusion of acetabulum here ratio, you can see it's 5 millimeters. Then I can go back, I think, Joseph, then you can discuss and you tell me which part if you want to review again. But those were the investigations that he did.
So what were the echo findings?
The echo findings, he had severe right hyperventricular hypertrophy, together with he also had thoracic aortic aneurysm.
Uh-huh. So only severe RVH and thoracic aneurysm.
Were the findings on the
Mm,
on the on the on the on the echo.
mm.
Also, he had reduced ejection fraction. Yes, so he had abnormal he had abnormal ejection fraction, which was reduced at 46.8%. Also, there was report on the hypertrophy. Hypertrophy on the ventricles, both the right and the left, they were both dilated. So those were the findings that
And the
I
CT?
saw on the slide. And I didn't have the exact final report from the radiographer, but those were the findings noted on the original PowerPoint.
So, okay, so I think we're running out of time. Let me do it. So the labs, the labs, the most important thing in that labs, what I'm seeing is the creatinine of 114. Unless this patient lost weight, we can say, yeah, and we knew the baseline, because to define renal dysfunction, you needed a baseline. If the baseline of this patient maybe was 70 and we are seeing 114, or maybe it was 60, you're seeing 114, it's a very a renal dysfunction. But this, for me, should explain now why is the patient not passing urine just because they have a CREA of 114. This is not much. So unless I know the baseline. The NT-proBNP tells us what we know already. This patient heart is failing. There is a stretching up of the arteries because it's too much filled with the fluid there, and then that's why they are producing it. Bilirubin being raised is not surprising because they have congestive hepatopathy. Can I see the bilirubin? Yes, and the direct is like more, which is the in keeping with the congestive hepatopathy instead of busting up of RBCs. So what I'm seeing in this EKG is the low voltage, and it's the low voltage of of most of these leads. Anything which is also important here, if I take lead 2, for example, go back to that. If I take lead 2, for example, and I just see the P waves, but in that V1, those P waves, I think that they're not how they should look like. Uh, so I wonder if the patient also maybe has AFib flutter. Uh, the rate is also irregular, as you're seeing that V1, it takes to the end. It's irregular, and you are seeing other, apart from the P that you should see, you're seeing also abnormal activities. So I think this patient also has AFib flutter because of the valvular heart disease that the patient had. Yeah, share it with someone who is maybe can see more than me and or hear what they have to say. So, as you're saying, the echo is showing the RVH, LVH, and the thoracic aneurysm was a reduced EF. Okay, let me pause here and say, why would one have RVH and LVH? Is the patient with hypertension. So if you see hypertension, RVH, LVH, you say, okay, fine, no problem, because they have resistance. But if they don't have hypertension, the question comes, why are they having RVH, LVH? And the answer is maybe there are stuff filling in the myocardium. There are infiltrative processes in the myocardium. Do we have them in this case? So that would be taking the case in completely other directions that I'm not prepared even to discuss about them. Um, about the valvular heart disease, I don't expect it to do that, and it didn't come out clear in that echo. As I understood you, Ryan, you told me there is the valves are okay, right, Roland?
No, Joseph, no, Joseph. The valves are not okay. He's also having valvular impairment, so they are not normal.
Okay, okay. Now at least that tries to make sense. But still, one have to explain this. Why would they have RVH LVH with that low voltage ECG, which means electricity is not passing well in those myocardium? That is an infiltrative process for me. That's an infiltrative process. So I put that aside. I say, okay, can it explain in the patient who's Marfan or a Marfan-like syndrome that has that pathology? So not interpreting the CT for me to be so hard, but I know I see they've measured that the main the main pulmonary artery or what I don't even know. I can't interpret that CT, Roland, unless I have someone interpreting for me. But I understand what these connective tissue disorder, especially Marfan, because to diagnose Marfan, uh, you need those things. There is a scoring system. If you have eye pathologies and you have all these things, you measure the diameter, I think, of I think the aortic root, and then you have the diagnosis. So maybe that's what they were doing there. Yeah, they have a dilatation of the aortic root, something like that. Yeah. Are we at the end of the case?
Yes, Dr. Joseph,
So,
you're almost approaching to the commitment of the diagnosis. I think from here, the next slide is to say on the final diagnosis, then maybe one or two investigation that you would need maybe to solidify your diagnosis. So that's it. So you're almost coming to an end.
uh-huh. Yeah, so I think this patient has, as Marfan as everyone also thinks, do they have a Marfan-like syndrome? I said that they call Lois Leeds, but no, they don't have that. Those others are so rare. I don't think they are implicated here. Marfan can explain a lot of things in this patient, including the appearance of the patient, subluxation of the lens, valvular heart disease that the patient has. Still, I I can't I can't align the Marfan with RVH LVH plus that ECG. That's an infiltrative process. I wonder if Marfan also does that. Uh, so at the end of the day, to diagnose Marfan, as I said, there is a scoring system. There is a name. Forgot the name, but I think you need genetics. You need the aortic root length. You need the length thing, and then if we put that, if someone googles that, we put that, this patient will score to be positive for diagnosis of Marfan. Teach me if I'm missing something.
So thank you so much, Joseph. Actually, you have got it right. So this patient, the final diagnosis, it happens to be Marfan syndrome, but it's presenting with acute decompensated heart failure, New York Association 4. Forester 2, secondary to valvular heart disease. On the examination findings, they're in keeping with severe mitral regurgitation and severe aortic regurgitation. Also is having aortic aneurysm. This is based on the findings of the examination together with the imaging. Also, the patient is having cardiorenal syndrome type 1 together with lens subluxation. So you are correct. Any suggestive investigation, you have already said that you would go for genetic testing. So for this patient, apart from that, it's also important to do a complete computed tomography or magnet resonance imaging for assessment of dural ectasia, apart from the fibrin 1 testing for Marfan syndrome. So the scoring system which Joseph you were actually asking for, it's called the Ghent criteria, which was lastly revised in 2010, where you have two arms. You have a Marfan syndrome patient who is presenting with Marfan syndrome, but you are thinking, is there a positive or relevant family history to this patient? Is there a negatively relevant family history to this patient? So if there is positive or there is negative family history of having Marfan, then it changes everything. So in presence of family history of Marfan, the ectopic lentis, the ectopia lentis plus family history, definitely equals to Marfan syndrome. But also, you also need to do the systemic score. You need to score the findings that this patient is having. So a score of more than 7 plus family history of Marfan syndrome equals to Marfan syndrome. If that is not so, when you come to imaging and there is evidence of aortic root dilatation or dissection plus family history, then that is equals to Marfan syndrome. But in a patient with a negative family history, in absence of family history, one has to then focus on the presentation, also together with the imaging findings. So presence of aortic root dilatation or dissection plus ectopia lentis, then it equals this patient is having Marfan syndrome. Or the patient is having aortic root dilatation or dissection plus mutation of fibrin 1. If this equals to Marfan syndrome. But to a patient now who is having aortic root dilatation with aorta dissection plus systemic score of Marfan's presentation greater than 7, then you are definitely sure that you are dealing with a case of Marfan syndrome. And what are those systemic score? These they involve wrist or thumb sign, pectus carinatum, hand foot deformity, and the rest. So looking onto our patient, what he had some of them, not everything, but he had most of them: the skin tria, myopia, scoliosis, protusio acetabulum. So our patient now had malphanoid features, which were noted as being positive. Wrist and thumb sign, you all saw that on the imaging. Scoliosis, there was reduced elbow extension, skin striae, and ocular examination revealed evidently that they were ectopia lentis. But at this moment, just from history, that means a score of 6 plus imaging to this patient, where it adds as 2 points from acetabulum. The patient had 8 points to solidify that we are dealing with a malphanoid patient. So what is the disease then? As Joseph said, and he got it very right, that it's a connective tissue disease affecting multiple issues, vessels, ligaments, and all those things. So it's an autosomal dominant connective tissue disease, which is caused by mutation in fibrin 1, in chromosome 15, which encodes for fibrin 1. So fibrin 1 is responsible for building microfibers, which are structures and elastic support for connective tissue. So 25% of cases are de novo mutations. Neither the parent is affected. So you can find one that the parents, they are normal, but the kid is the one affected, like our case here. But one thing striking is that there are no specific lab tests to solidify that this is Marfan. So as Dr. Joseph was able just to pick from the just to pick from the diagnosis of Marfan, it's pure on clinical criteria, the findings, like the ocular findings, the cardiovascular findings, and other systemic findings, the musculoskeletal findings. Then, on addition, then you can go for molecular genetic testing to affirm your diagnosis. But the prevalence now of Marfan syndrome, it's at 6.5 per 100,000 people globally. But there is no published prevalence existing for Africa, despite having multiple case reports like this one from MNH. So it's a key research gap that we are having. So Marfan syndrome has a broad spectrum of clinical severity, even within the same family. As on review of family history, we see that the sister is also tall, but she's not having this clinical manifestation, even though we are thinking that she too, if we do thorough investigation, high likely that we are also going to find she's also a Marfanoid patient. So the pathophysiology of Marfan syndrome, it all starts with fibrin deficiency, then with affecting every other thing, coming to even to aneurysmal dilatation. So this slide actually summarizes the pathophysiology of aortic aneurysm formation in Marfan syndrome, starting from the primary molecular defect and ending with aneurysm dilatation. So beginning with fibrin deficient. This is caused by mutation in this gene. So mutation in this gene, which is the key component of extracellular matrix and normally sequestered as latent transforming growth factor. When there is deficiency of fibrin, that means there is deficiency of control to transformation growth factor beta. Now this will lead to bioavailability loss and resulting in excessive and dysregulated TGF signaling, which if left unchecked, it is going to lead to aortic wall deformities. Then there is that part of inflammation and fibrosis, cystic medial degeneration and wall weakening. All these processes, when they occur, they are going to lead to aneurysmal dilatation, which it was also picked to this patient through imaging. Now, the can see and we can all appreciate there are those skeletal features, there are ocular features together with cardiovascular manifestations. In skeletal features, there is a arachnodactyl, pectus carinatum. Our patient didn't have pectus carinatum, but he had arachnodactyl. Also, aortic aneurysm and mitral valve prolapse, there are also possibilities. But ectopia lentis or myopia, as we saw to this patient. So these are, when you see these features, you should have high clinical suspicion. Maybe you are dealing with Marfan syndrome. But imaging studies now, they are very important. Echo, CT scan to affirm what is the vascular status of these organs which they are affected during Marfan. So confirmation of diagnosis, as I said, there is no specific lab test. But however, if there is room for doing fibrin 1, it is very important because it is the one now which is going to establish if there is mutation. But the rest of investigation, they are just supportive to see to what extent the vessels are damaged, the heart, the lungs, and the other things, or the eyes. It's also important to think of other differentials such as Loeys-Dietz syndrome, which is a very, very important clinical diagnosis which mimics Marfan syndrome. And echocardiography, it's important. It's important is two things. We need to do echo during the diagnosis confirmation to this patient, and also repeat it after 6 months to track the aortic root or aortic ascending diameter growth rate. Coming to management, um, the mainstay or the main key in managing Marfan syndrome, mostly you are going to see the patient will have cardiovascular symptoms, and mostly they are in keeping with heart failure. So the five pillars of the four pillars of heart failure are to be highly have to be highly optimized in this patient. So the use of beta blocker, which we know the aim to have reduced cardiac contractility. The ARBs and other RAS medication, they are very, very important. Um, Procedure of choice to patient with Marfan syndrome is called bento procedure, which is specifically a technique for composite graft replacement of the aortic root and valve with coronary implantation. So it's a surgical procedure which is done, but however, the procedure has its own shortcomings, as we can see on the right side of this screen is the survival rate. It has 84% survival rate between 5 years. For 10 years, the rate of survival is 75, and the rate of survival after 20 years is 59. So the long-term outcomes, the early mortality is a bit reduced to 1.5, and the survival rate is still very high. And however, there is risk for thromboembolism, especially at 20 years, and endocarditis at the age of 20. So coming to particular of our patient, how was the cause of illness? Remember, the patient only had systemic manifestations. I mean, the tall stature, the eyes and everything. But however, there was something underneath going on. So at the district hospital, he had presentation of shortness of breath and fatigue. So they were querying, are we dealing with heart failure? Yes, it is heart failure, but secondary to what? So they sort of dilated cardiomyopathy. So they did refer this patient to a regional hospital. At a regional hospital, the patient kept on presenting with worsening symptoms of heart failure. So they had to refer our patient to JKCI for cardiologist review. Um, at JKCI, echo was done and revealed vascular and valvular abnormalities. And currently, our patient is at MNH and is scheduled for bento and for bento procedure together with mitral valve replacement. So the patient current management is still, as I said, is on heart failure management together with rivaroxaban, and he's awaiting for bento together with the mitral valve replacement, which has been scheduled to be done into this ending week. So maybe follow up if it's done, we can know if it was successful. So reflection, we can remember maybe to some of us who maybe you are interested in geopolitics. So this tall man here was a French president. He was called Charles de Gaulle. He was one among the famous people with Marfan syndrome. So this marks the end of the presentation. So it's up to Joseph now to give the reflection, and then we can call it a day. Thank
Um,
you.
uh, I'm blown away. Thank you very much. It's a nice case. It's not about the diagnosis alone, but the problems. So nice to dissect them. I understand Seba is not here, but if David is here, I still uh, can't figure out why would the patient have RVH, LVH plus low voltage EKG. If David is here, maybe they can tell us, and we should close. If they are not, we close. Oh, Adriano Tobias. Welcome if you have an answer to that. Or you had your own question or addition. Oh, okay. So Nothing. I think, yeah. So let's, for everyone, when we go back, sit back and think of that. Why would the patient have LVH, LVH plus a low voltage ECG? For me, that's an infiltrating process. Maybe the patient has both of them, or maybe something with Marfan, but that needs another explanation. So thank you very much. Yeah, Rajab, we have
Hello,
something.
Joseph. I see Rajabu has a hand there. I'm been in and out. Let's hear from Rajab.
Okay, so firstly, thank you very much for a very good presentation, Dr. Roland and Dr. Joseph, for detailed discussion. So I think, I don't know, but if I look at the echo, I know they just did the M mode, but if you look at the LVID, it showed that it's 7.12 centimeters, something like that, which is increased. And also, not only that, so for us to know if it's true hypertrophy, because we have two of them, of the concentric one and the centric one. So we needed to know also the what RVW relative wall thickness, RDWT, of which in this echo they did not mention it. So the one which is we are worrying, Dr. Joseph. So we are not sure, is it true per se that we had the LVH as they said, or no, or it was dilatation as it seems from the echo. So basically we needed a report or a detailed echo report. Then I have another issue on aspect on the physical examination. So we have the pulse deficit on the physical examination, which was 16 actual, which was high. And also on the ECG, on the, one aspect of the ECG, if you go to the rhythm strip, we know that it is irregular rhythm, and the numbers of QRS are more than compared to the P wave. Actually, for me, I think those are F wave rather than to be as a P wave themselves. So I don't know in per se, but what I see, there are features of atrial fibrillation in this patient also with respect to the ECG with the normal pulse. I know most of the time we have the tachycardic form of atrial fibrillation, but you can have the normal pulse. Again, we needed, I think, the detailed echo to assess for the aspect of the aortic valve and also the mitral valve to know what they are finding, the finding they have, because this patient has one among of the genetic condition, and in aortic itself they can exist also with the bivalvular aortic valve. So we needed to know on aspect to the OT to the valve, what did they find per se. Yeah, so that is what I wanted to add on this aspect. And again, so this currently people push on the diagnosis of heart failure. So I think because here most of us are physicians, we can discuss on this, on the aspect of using the American Heart Association with American cardiology, classification of the from the stage A to the stage D. So they are pushing this because it is one among of the things help us to detect early as a patient occur on stage A, which is the risk factor for them to develop heart failure. So in the diagnosis is one among of the things we should include. If someone is stage C, we know what management we are going to order, and if someone is stage D, this is where you can opt to give other management, including the device management in this patient, or we can consider transplant to those patients who they required. Thank you.
Rajab, you're very intelligent. Yeah, those are very helpful. I can't look at an icon and say all those, but thank you very much for the elaboration. It makes sense now. And yes, I also saw that. I think it's an AFib. We expect it in patient with valvular disease. So yeah, thank you very much, Rajabu. Thank you, Ed. Also, very good explanation. I think we should close. We are beyond an hour mark. Thank you, everyone. See you next week. Have a good night.